Hello and good day. My name is Jeff Prescott. Welcome to today's webinar, How Biosimilar Rebates Shape Payer Policies and Provider Behavior. Our program today is brought to you by the American Journal of Managed Care. Today's panel consists of experts that straddle both clinical practice and business affairs. We're going to discuss managing logistics and economic challenges that accompany the availability of multiple biosimilars for specific reference products. Now, today we're going to have a discussion with our panel, and then following that, if we have time, we will be able to take some Q&A from the audience. If you look on your platform, there should be a Q&A button right below towards the bottom of your window. Use that and be able to submit questions to us at any time, and they will get to them at the end of the program as time allows. All right, so let's get started. Panelists, would you introduce yourself? Kathy, would you start, please?
Sure. Hi, everyone. I'm Kathy Oob, the Chief Operating Officer of Pontchartrain Cancer Center in Louisiana.
All right. Ali, would you introduce yourself, please?
Sure. My name is Ali McBride. I'm the Clinical Coordinator for Pharmacy at the University of Arizona Cancer Center.
Great. Thank you. And Tim, would you introduce yourself, please?
Hi, my name is Tim Chu. I'm a pharmacist, evidence analyst, and strategist with Kaiser Permanente.
Super. Thank you. All right. So let's get right into it. So to ease us into this conversation, let's talk about the significance of biosimilars in general for improving access to patients. Tell us, a little bit about what your thinking is and what you've seen so far. Kathy, would you start us off?
Sure. So we first started working with biosimilars this past year, back in 2019, in the pegfilgrastim space. So Udenyca and Fulphila as the biosimilar for Neulasta. And over the last several months, we've started seeing that in much more of the therapeutic space with Kangenti and Mvasi and some of those other biosimilars. From a community oncology perspective, those have, the biosimilars have really presented a good cost-sharing alternative for our patients, because they are less expensive than, for the most part, than the originators. So when we're looking at, therapy choices for our patients and, when they're in that cost-share model, it's really provided them access to good quality medications at, a less expensive out of pocket for them. Ali, what are your thoughts on that? What do you guys see?
So no, I think we bring about the pegfilgrastim question, right, which I think is a very big conundrum question where we had the introduction of, a long-acting, a very cost-heavy biosimilar. We were actually very familiar with biosimilars very early on with the first biosimilar, the filgrastim Sandoz product, where that actually led to a very quick implementation. Really thinking about this, going back in time, Kathy, we were looking and we saw the implementation of that filgrastim short-acting product to actually occur much quicker. When we started looking now towards the pegfilgrastim product, I think we're seeing some variations in terms of uptick, and it's not by institutional basis. Looking at the whole U.S., there's variation based on how they're implementing this. But I think we are seeing, for those people who we do actually try to change to, and other places across the country are seeing this too, it's actually more dependent on payer. So yes, our familiarity is really changing right now. And, we're seeing a lot of work being done by our nurses, physicians, pharmacists, our finance teams. Really the kind of like the unsung hero here is our finance team as well, in which we're moving to actually facilitate that transition to a biosimilar. Really right now, we'll talk about the pegfilgrastim-based products and also the reference product here. We're trying to change it, but we actually are getting payer pushback. So all that work we do, faxing information, financial assistance, doing all the groundwork up front, which is so important to get that patient started. We're getting a little bit of pushback, if not a lot of pushback, on the pegfilgrastim product here too. So that's been one of those things where we've been working on it and addressing it. So that's been a hesitancy, but also, utilization. We also do same day here too, same day pegfilgrastim. So we've been actually trying to educate our payers on that as well. And that's provided some information up there too. So lots of variations up front in regards to uptick, transition, and really mobilizing these change. And I think just talking about the supportive care piece, as you alluded to, and I'd love to hear how this discussion unfolds. We're getting a lot of pushback based on payers. And as payers unfold, maybe next year with 4, if not 5 biosimilars to in the market in the peg-filgrastim long-acting space, that may even be parsed out next year. When we renew the insurances and update what their preference is, we may have to switch to another biosimilar at that point in time too. Is that how everyone else is seeing it as well in regards to this?
We are definitely. You know, biosimilars are one of the very first times I can remember where, you know, payers are really taking an active stance in dictating the drug that the patient can receive. You know, we're not seeing parity with the biosimilars, or very, very rarely are we seeing that. You know, when I'm seeing increases in formulary decisions as the months go on, you know, we saw it with one of the largest payers back in October in the peg-filgrastim space. But over the last several months, you know, we've not seen parity increase, we've actually seen it decrease. And some of the other payers are making business decisions for, you know, various reasons. And we're seeing, you know, sole source formulary continue to increase. We actually have, you know, 3 more payers that implemented that for July 1, and we have to respond to that. So it is difficult to participate in the biosimilar market. We do, and we would like that to continue, but it's a different world when the payers are dictating what we are allowed to give, and especially when each payer may pick a different biosimilar. It presents a lot of operational challenges.
Okay, so let me ask and start to walk down that road of operational challenges. So let's pretend payers didn't exist for right now, and we're coming up with a situation. So it may, you know, it's possible somewhere, but so we have now our new world is that we have multiple biosimilars available for reference products, and you can be able to utilize those at your discretion. Very similar, and I don't want to use the pun there, but similar to our experience with small molecule generics. What does it look like for you to? What would you be doing? What does your pharmacy look like? What's your stock like? What would you be doing if you had freedom to utilize a variety of different biosimilars? Ellie, why don't you start out with that one?
No problem. I think, you know, looking at this, if we're trying to look at a payer-based discussion on this model, the biggest piece from my perspective is a European model, right? Where we'll see biosimilars, if not brand name therapies, interchanged at either quarterly or yearly intervals based on contract pricing. There is no payer involved, right? And I think that's what we're assuming in these discussions, where the lowest price obtains the best contract. And Europe has been doing that for years. Whether it's a non-oncology product, whether it's a brand name product, whether it's a therapeutic biosimilar for supportive care, or a curative supportive care therapy, which is what we're seeing right now. And I think right now we're on par with Europe's expectation. They're about a year ahead of us in the rituximab biosimilar market, but right now we've caught up with them in regard to therapeutic oncology. The other biosimilars were way behind, but for therapeutic oncology, we're both learning at the same time. Now, when we're taking a look at what's happening in Europe, what they do is they'll actually have a contract in place. They'll buy a certain product, it's that price, and that's what they use. So the whole formulary within that system changes, and that's actually based in the country. When we're looking at exactly really what Kathy was talking about is looking at hesitancy or practice-based contracts, you know, with the payer and the drug, that actually sets us up for a different discussion, which is a lot more work being done upfront and also on the back end. In fact, you know, it makes us a little bit more hesitant to switch because we have to do all these groundwork pieces. Then you switch, and then at the time you switch, guess what? You have to go back to the brand name product. And that really, you know, you're looking at maybe 10 to 20 hours of FTE work, really looking at everything from working on diagnosis, chemo entry, you know, submission with finance, patient assistance. And also don't forget, if you switched and you're under certain CMS contracts and you don't follow up with maybe a supplemental, you can also lose that and have a rejection on the back end. And that's a very simple workflow for what we're seeing. In Europe, you don't have that. And so if we're looking at what a guiding light is, not saying it's the best option, but saying it's what they do, it really reduces the time to enable the transition to a biosimilar. And right now, we're talking about supportive care with pegfilgrastim, but I will tell you, when you're looking at therapeutic oncology, the transition's even slower, right? You know, looking at the bevacizumabs, the rituximabs, and also in these cases, trastuzumab. So we're constantly working to address these pieces. And if we're able to do it, as Kathy actually said it the best, parity. Parity will be crucial to implement biosimilars across the board. We know Senate is right now, you know, with them back up and mobilizing. Hopefully they have had discussions about biosimilar entry and preventing the actual non-use of a biosimilar, or maybe not using a biosimilar by payers in these cases. The only way to do this is actually have a federal parity piece, which would allow for blank slate utilization of biosimilars, and also prevent the inhibition of biosimilar uptake. And in itself, that may lead to higher patient costs as well. So that was my pie in the sky idea. I would love to see more of a European model for increased utilization, but in as such, also make sure that we prevent these barriers for biosimilar implementation. I think the one thing that I'd like to see from this discussion is, what is the copay between those patients who are on a brand or a biosimilar? And in those patients who are not able to get the biosimilar, is there a higher copay for the patient? That's one of those questions which I think is still stirring in some of our minds too.
All right. Kathy, do you want to add to that? It's so again, freedom to be able to host, utilize multiple biosimilars. Would you be doing anything different in your institution?
Yes, but I do want to first comment on Allie's last comment about copays. So I do believe in biosimilars. I like looking at the math behind it all and the cost savings to the practice, to the healthcare system, to the patient. So at the beginning of a year, and Tim knows this better than anyone, everyone's deductibles reset. And so in our practice, we do a financial analysis for our patients when we're authorizing, their drugs. And so I thought it would be kind of fun for everyone that was on, or had the option to be on a biosimilar. I did the math for everyone based on their deductibles, based on their copays. And in almost every instance, the patient had a lower cost share if we had been able to use the biosimilar. Now, in some insurance companies, that's not a choice. We are required to use whatever they have on their formulary. But I did keep all of my data. And in almost probably 90% of the patients that we evaluated, they all had a lower cost share to them when we were able to use a biosimilar. Now, in a perfect world, going back to answer your original question, parity would be great if payers, weren't there, but they are. But in a perfect world, we would use biosimilars. We believe in the science. We believe in the cost savings to the healthcare system, to the practice, and especially to the patient. Because at the end of the day, we all know that term financial toxicity, and it's certainly not going away, especially in COVID. When people are having insurance, losing insurance, they're not sure, unemployment benefits. It's incumbent upon us as good stewards when we're caring for our patients to ensure high quality treatment at low cost, but especially low cost to that patient.
Okay. Tim, again, so the question, it sounds like from what I've heard, if there were multiple biosimilars available for a similar product, you would, Kathy and Ali, you've said that you would still try and focus on the one that has the best economics attached to it. Tim, is that the same? I mean, would you be stocking multiple? I mean, in some pharmacies, I would say my experience for small molecules, generics, there's some occasions you might have multiple brands on the shelf. You would try and stick with one. But I think our experience for those is that sometimes you may switch on a dime to go from one manufacturer to another. How does something like that, and trying to keep track of that over time for these type of products, how realistic is that?
Yeah, no, that's a great question. And I'd like to echo, I think, what Ali was talking about earlier, in how, or at least bring it up where using the European model as a potential guiding light, I want to highlight that Kaiser is a bit of a unique structure too. So some of our experience may be unique compared to the rest of the country as an integrated model. With that said, we have our share experience, especially with small molecules, trying to deal with these potential complications. And so when the biosimilar era approached, I think historically we had a lot of success to try to focus on one preferred product when that's possible. From a simplicity standpoint, it reduces the issue for operational challenges and errors, as I think all the panelists have alluded to. But I think, to be honest with biosimilars, there is a lot still, even though we've had biosimilars around for about 5 years now in the United States, I still find a lot of misconceptions and lack of understanding about biosimilars. And I think one of the questions out there that continues to be brought up is, can you switch? Are they interchangeable? And there's this uncertainty and uncomfortability around that topic still. And so if it's from just a simplicity standpoint, trying to make or ease that concern, even with all our understanding about the data supporting biosimilars, I think that's just one example that highlights that if it's possible to go with one product based on the totality of evidence and the access and affordability component with that, it just helps with a cohesive message. And you probably find, or at least this is the experience at Kaiser, that it's more efficient to try to get that buy-in moving forward with that kind of plan in place.
Yeah, absolutely. So given the fact that we do have, as we do have payers, and sometimes I would say everyone here has multiple payers involved in supporting your patients. And if a payer is mandating use of one specific biosimilar and another is focused on another biosimilar product, how is that, how are you handling that? Are you keeping everything in stock? What are some of the challenges that become associated with having to do that, setting up multiple entries? Again, it's on the small molecule. That means different insurance companies or payers are telling you to keep multiple brands of the same product essentially on the shelves. Kathy? I think you're muted, Kathy.
Sorry, everyone. I was trying to follow the rules. It does present a lot of unique operational challenges, but it begins at the treatment plan. So when that physician's writing the orders, that's that first stop where, the physician needs to be mindful of what insurance company the patient has. So then it goes to that authorization team. They're usually that second stopgap in case it is the wrong, what's not on the formulary for that particular insurer. Mm-hmm. And then, then you have to establish all sorts of, workflow stopgaps to ensure that the nurse doesn't administer the incorrect or the non-approved biosimilar to the patient or the non-approved product. So, we've had to put pop-ups and stops in all of our, our EMR workflows, to where the nurse has to, sign off on it and put her initials in, mm-hmm. Stop. Are you sure you want to administer Udenica to this particular patient? And it does help because we don't want a nursing error. If you administer the unapproved drug to the patient, you won't get paid for it. And then, that's a problem. It also harms us from a contract perspective. We have to admit it. We work in a buy and bill space. Everyone works on contracts. When I'm required to stock multiple products, though, that harms my ability to perform on any type of contract with my GPO. So that's another issue. Drug margins are thin, and a lot of times we need to be able to do those things. And Ali brought up a good point when we don't do anything mid-change. We don't change anything in mid-quarter because all of our contracts are measured on a quarterly basis. But when a payer makes a formulary decision, that takes work that you're paying, FTEs to be able to then reauthorize new products. And that can become an operational nightmare at the beginning of any quarter, but especially the new year.
Okay. And it's, so if I can ask, in just a certain situation, if there was a mistake and the wrong biosimilar was administered, and you said you won't get paid for it, would you seek to keep the patient on it if there was if their treatment plan called for it, or would you try and switch it back to an approved product?
No, we're going to switch it back to the approved product. I mean, we can't take that kind of financial hit.
Okay. So even if, yeah.
I was going to say, I think that's the critical question right there, right? And, Kathy and Tim, to add to this, if you don't have that drug approved, you're at a financial risk already. Mm-hmm. So by actually maintaining whatever your formulary is, puts you at risk in an outpatient environment. If this is an inpatient discussion, it's a totally different story. If you're under a DRG, again, if you're a PPS exempt hospital, it's a whole different discussion as well from that standpoint. But when you start thinking about these switching and going back and forth, you're really at the hands of the payer here. So unless we know, whatever, I think the one thing that I would love to see, I haven't seen it yet, is I would love to see every biosimilar company come out with what they have a product, who is covering their biosimilar. So you can go back and look at your own portfolio and say, this is where it's going to be covered majorly. I feel safe, right? That's something that we're all working on doing. But I think that the discussion also kind of pars back with Kathy saying, you don't want to switch, you have to switch, you don't want to switch midpoint. But you know what? If they switch contracts at the beginning of the year, or maybe it's mid-fiscal year, whatever the case is, based on these contracts, you have to shift all of your products to that other therapy, right? And what I'm scared at, and this is really what keeps me up at night a little bit, is if you get that approved and they give you 6 months, but they don't tell you to switch in their formulary, you may be giving a product which was approved for 6 months, but it's the wrong product line. And so in these cases, you start to live these nightmares. So you get a big denial. Then you have to get your free drug with your patient assistance program. So you can only imagine how that parity discussion, which really Kathy touched upon, which I think we're hearing more from across the country from many institutions, whether small community practices, large academic hospitals, or intermediaries between those, is the fact that if you do have parity, and you can say, this is my institutional biosimilar, this is what we're doing with this, we're going to be switching it. I look forward to how Tim's going to actually evaluate this too. You do that broad switch over, that should not affect your workflow. There should be no workflow changes other than your IT information with your teams and patients, healthcare professionals, and also addressing your financial assistance program. But the problem is, we're looking at constantly switching across time. And then as you talked about, what do you keep on stock? What do you keep on your shelves? If you know a patient is maybe that one small payer that requires another biosimilar, do you kind of do a drop ship, which you probably will have to do, and wait till they come in and get them a few days before? Or in these cases, are you going to have that on hand? So you're having an on hand, lean-based workflow versus that of actually having a robust inventory, which kind of dings you in that overall lean model. So what we've been taught before for the last 6 years with lean, in regards to Six Sigma discussions on inventory control, actually will not be maintained in these pieces. So it's very interesting to see how this is going to affect us probably within the next year. But we're just talking about, as an example, a pegfilgrastim product. We have not talked about the curative biosimilars such as trastuzumab, bevacizumab, or rituximab, where with bevacizumab, we may have 6 biosimilars available to us by the end of this year. What happens if you have 23 different types of payers and PBMs involved? and they all require a different one. So just imagine that wonderful sleeping nightmare, as we say.
Yeah, absolutely. How, and you mentioned, trying to be lean and such the number of combinations and permutations. I mean, how do you think about managing logistics like that? I mean, is it something where you are just not keeping things on the shelf? How do you prepare to leading up to logistics to support patients like that? Again, or even possibly, whether you're doing it now in some instances, or, how might you do that? Tim, can you tell us a little bit about your thoughts on it? Then we can ask around.
Yeah, I mean, I think luckily Kaiser has the infrastructure and the approach where that may be part of the rationale why we try to go with one preferred as much as possible. So currently that's been mostly successful in all our biosimilar efforts. And so practically speaking, when we do need to utilize or consider other potential biosimilars for a specific reference product, we are often doing that in more of the drop ship model, not having to stock, just because it's a little bit more efficient and based on our current market share. But that said, I think these are the types of questions that we're having to deal with in our own unique way too. As Kathy mentioned before, the timing in terms of when you potentially would have to have these conversations about switching or how it plays into the financial calendar. These are coming up for conversations within our own institution as well. So if it sounds like we need to make a transition, or if there is the opportunity that we need to have two potential biosimilars with fair market share, then that's something that we do have to plan for in terms of ordering and stocking, and even things where we need to start depleting current supply in preparation for some of those potential transitions. So ultimately, I think we're in a bit of a unique situation, but we do see it, and we have to. It's not as efficient when we have to go into those situations, which is an issue.
Mm-hmm. Okay. So, given some of the challenges and possibility and permutations, combinations of who's covering what and which product, what have your conversations been like with payers up to this point? How are they preparing or talking with you about this? What information you received? Kathy, let's start with you on that.
It depends on the payer. Some are a little more receptive to having these conversations on parity. Some are not. So I think it depends. And, as Ali mentioned a minute ago, and again, Tim, I'm not trying to continue to take a hit at the payer, because I understand, we're all kind of talking about picking one drug. But I think from the end user perspective, it is a little more fraught with risk for us, because we might have 23 payers. And if we have 6 or 7 biosimilars on the space, and some of those payers, and now what if we have to stock all 7? That's a huge risk for us, for a practice, a large or a small institution. And so it's something that we're trying to work with those payers on is, okay, I get it. If they want to pick 1 or 2, I would prefer parity. But, if the end user, if I have to stock all 7, that really is a risk issue, especially from a nursing perspective. As I mentioned earlier, we've tried to put our workflow things in place to minimize our risk. But at the end of the day, that's the kind of stuff, like Ali mentioned earlier, that's the stuff that keeps me up at night, is, being able to hone those workflows, educate your staff, new nurses, all of those things to minimize our risk, to be able to keep our doors open and treat our patients.
Mm-hmm. So I've heard the continued need for education, and again, biosimilars have been out for several years. What's that continued education like? Whether product agnostic, whether is talking about it in general, is it something that comes back up when a new biosimilar comes into the market? What's it like? What are the continuing educational needs for different stakeholders?
So I'll address it actually with the Herceptin piece, because most patients are pretty easygoing about pegfilgrastim and a couple of the other things, but women know Herceptin. And that's been the one piece of pushback that we've ever received is, you know, there's still a little bit of that education gap in the biosimilar being an inferior product. You know, I don't know if Ali sees this or Tim hears this at Kaiser, but that's the one barrier that we have on that. Guys, what do y'all hear?
Well, I see. I don't even just have to hear it. I see it too. You know, you're absolutely right. When we're taking a look at therapies, you know, for many years we've been looking at supportive care, right? We've done infliximab, non-oncology. We've done supportive care with growth factors. You know, insulin's coming on board too. So it's going to be very easy for us to look at numbers. And that's what we've been doing. We've been looking at these short-acting growth factors, long-acting growth factors. But now you've created a conundrum of therapeutic oncology. And we have therapies, 2 out of those 3, which are curative. We have trastuzumab in the breast cancer setting. And in those patients, they're very vocal. We also have rituximab in the lymphoma, leukemia setting as well. Another curative option. Bevacizumab, again, in these cases, really hasn't been much of a pushback. And I'd like to hear how this kind of rounds out too. So when it comes to these evaluations, looking at these therapies, we really do believe that there's a lot more discussion on therapeutic oncology with curative intent. And that curative intent is what has caused some questioning of switching, of starting in these settings. In fact, a few years ago in ASCO, and they just did a recent one update recently too, is they looked at curative therapies and they asked physicians in Europe what they thought. And they had said that they would actually maintain a reference product to start off with. And therefore they wanted to maintain that reference brand product. But then later on, when it came to relapsed refractory, they were more likely to switch to a biosimilar. So there's that curative intent, you know, discussion right there. So we have heard that. We have actually seen more of this discussion. I think there's going to be a lot more education on the curative biosimilars. In fact, you're probably in several years on this, addressing misnomers, looking at real world data, looking at the outcomes on these actual biosimilars implementation. And that will help provide confidence to the patient and also our prescribers as well. So I think we're going to have to do a lot of work on that. I think, you know, what Kathy is hearing is exactly what I'm seeing and hearing too, is there's a pause in terms of switching to that biosimilar on those 2 therapies. The bevacizumab in these cases, we can switch right away. And that hasn't been much of an issue in that implications. But I agree 100%. Unless the payer says you have to switch now, there has been hesitation on the patient, which is interesting, right? And also our prescribers too, unless implicated by a payer mandate to switch. So we're seeing that. So again, from an education standpoint, you're looking at a lot more on these therapeutic oncology-based outcomes with switching to the biosimilar piece too.
Yeah, and I think Ali brings up a great point of that real world data. I think that's what a lot of prescribers and patients, I think that's where we lack in that education piece we need. We're in the infancy of our biosimilars. I think we need another year, 2, 3, 5. I'm not the scientist here, I'm the operations person. But that's how, you start to really pick up in that biosim market, is that, finally getting to that delta of real world data where it's actionable for the physicians and the patients.
Okay. What do you feel are some opportunities? Again, we talked about the education need for real world data. What is it that payers, again, if they're directing to be using a specific biosimilar, specific product, have they been providing any education or at least information to patients, to working with you providers? What have they been doing? What would you like? What would be good here?
I could jump in. Okay. Oh, sorry, Kathy. Feel free to go first if you'd like. I can hold.
Tim, we'll let you go.
Yeah.
Thank you. I can speak to what Kaiser's been doing. I think and this may echo the points that were brought up by Kathy and Ali just previously. But I think the educational component is extremely important. Our own experience as we approach each biosimilar, as they've often been with new specialty groups, we hear a lot of the same questions and some of those potential misconceptions. Even though biosimilars have been around, I think they can be relatively new for certain physicians as they get into those areas. So with that experience in mind, the way that we've approached it as a payer to try to provide education and get that kind of buy-in from both physicians as well as patients is to have sources like FAQs or educational decks that can serve as a general kind of information hub for a diverse audience, so that there's a general comfort with the regulatory pathway, the type of information that leads to the approval of a biosimilar. This, again, Kaiser tries to pursue one potential biosimilar as a preferred, and I realize the complications and uniqueness of that aspect. But that also serves as an opportunity where these educational materials can speak to some of the specifics with that particular biosimilar that may provide a little bit of benefit. And this is not to say that if a potential or a particular biosimilar did not happen to study a specific patient population as their confirmatory clinical study. For example, some of the trastuzumab biosimilars looked at advanced breast cancer, so in the palliative setting. But if you have some that were investigated in early breast cancer and the treatment of patients in the adjuvant setting, as an example, that may help to buy some confidence even from patients. And so those are the types of information that we try to utilize to tell that overall story. We at Kaiser, we've been big proponents of biosimilars and want to see their success, which is why I think ultimately we want to focus on education about biosimilars and that pathway overall. But there's also opportunity to focus in and hone in on some of the specifics to each biosimilar as well.
Okay. Kathy, did you want to add to that?
Well, sure. We've actually been working with employer groups a lot, and I think they would like to see more information, more education come out from the pharmaceutical companies. I personally have not seen any education pieces come out from payers regarding biosimilars.
Okay.
And I do think that biosimilar manufacturers need to do a better job of developing education pieces. I personally don't see a lot of it coming from those particular manufacturers. I don't know if you see differently, Ali, but we're creating most of our own. There's other organizations out there that have, education pieces, but we're creating our own decks to work with, payers, to work with employer groups. And employers really want to hear more from pharma partners, from us, on how to educate their employees. Because the last thing an employer wants at the end of the day is to pick a particular biosimilar to put on their formulary. And then, a female breast cancer patient, gets upset. I mean, at the end of the day, she's going to get upset, and I get that. She wants to have confidence in that product. And an employer never would want to be viewed in that light, as picking an inferior product for their, for their employees.
No,
what do you say, Ali?
I was going to say, adding on to that, Kathy, I think I love the discussion here about education, right? And that's one of those key pieces, because you have your education within your system. And so within your system, you have your financial advocates, which they didn't go to medical school, right? And yet you are primarily working off of them to get these high cost therapies paid for. And then you also have your financial assistance team, medication assistance program team. Again, the same situation, making sure patients can afford their drug, making sure patients can get free drug if it's off label, or maybe there's a denial there too. So I think you have education level with your financial team, if not a salient piece of that puzzle, which is often missed. Then you have your healthcare professional team, which means you're going to be addressing that with people who are your nurses, right? And they may be the ones hanging that drug. And the patient goes, what is this? And the worst situation is to have your nurses unprepared. You always want to make sure you take care of your nurses on a daily basis. So you have your nursing education. Does it look alike? Does it sound alike? You have your physicians as well. So those are important things. We even had one biosimilar, which the packaging looked like another brand name product, and that led to medication errors. So again, looking at these small things, and I know they sound small from a granular perspective, but when you're doing 100 to 200 infusions a day, and maybe those are 10 or 20 repetitive-based therapies, that's important. So I think that there is that layer or level where we're doing a lot of education from that standpoint, but I think it's lacking. We are seeing some good data come up from some CE reviews. Again, we've seen several of these areas. I think we need probably a lot more of that. I also would love to see some pieces or education to patients, right? That's something that we don't see at all. How do we educate the patient? Like have a non-branded data set for which we can utilize that. I think there are two which actually come up from the education piece. You know, again, making sure that we are educating our pharmacists, physicians, nurses, advanced practitioners, our finance team, even our operation team members, so they know what these are. But, you know, I'd love to see some more discussions about alternative payment models like OCM, OCF, how biosimilars may implement those, and also the macro MIPS discussion as we're seeing a change in CMS basis over the next few years, in which these new cost models will actually have to increase utilization or uptake of biosimilars to reduce their overall payment rate, right? And I think we're not talking about that enough, even though we constantly hear the high cost of drug prices. So what does the education mean? Like, how do we have a formula to implement biosimilars, and what does that cost reduction mean for OCM metrics or OCF metrics or macro MIPS metrics as well across the country? These are things that we need to address. Even the discussion on copay accumulators, right? How does that actually kind of tie into these? I see Kathy and I like, yes, you're speaking my language here. So yes, this is, so again, these are all different pieces of education, but those are key components, as well as IT infrastructure, something we have not talked about, because every single institution may have a different IT system across the board, maybe going to paper, charge, billing codes. How are you doing this? And also the other piece, which may or may not be in effect based on site location, is investigational trials. Some of the biosimilars are not being added into the trial protocols, so we have to go up and actually double check, and this is across the board, to make sure those can be utilized in these settings too. So that's an overall perspective of what education needs to be done and where we need to address it from, just from an overall piece of the puzzle, which hasn't been done for all aspects, as well as I would love to see the data there from real world data every year. Let's see what's happening with data from your perspective. We want to have that data up front. And Europe does a great job. They have every different study possible, modern GCSF. They have a constant pharmacovigilance discussion. You know, and this is really where I'd like to see, you know, Tim also add to this piece, and that's really up your discussion in regards to what you're doing. You know, what is that real world data looking like, and do you expect to report that out if these come up from a P&T perspective too, Tim?
You know, another opportunity is, you know, going to payers and employer groups, and even CMS is talking about this, but a shared savings model. You know, it's a very low risk proposition and basically can sit on top of, you know, anything that, you know, CMS and, you know, CMMI have going on right now. We're working with a couple of one's payer within our state and one large employer group to do a biosims shared savings model. So that's, you know, I'm really excited about that. I would love to, you know, I hope to get those wrapped up by the end of the year. And I think, again, when we talk about real world data and being able to show savings in such across the spectrum, I think we need to all as practices start working on collaborating with our payers and our employer groups to get that.
So, Tim, if you can speak to that, since you have, I think you may have the best access for a closed system to monitoring not only just acquisition costs, but the overall impact. How are you doing that along the lines of biosimilars? And, you know, we even talked about the product cost. You know, is that something that's being monitored like other branded products? You know, how are you keeping an eye on that either today or as we move forward?
Yeah, no, that's a great question. And just to quickly circle back to Ali's comment about potential pharmacovigilance and reporting, that is, or starting with that as part of the discussion. I think that's part of how we approach each discussion with specific biosimilars in our approach at Kaiser's. And it's not just because they're biosimilars, but biologics in general. I think the FDA has stated pharmacovigilance is very important for these. These are complicated molecules, not like the small molecules. So and it's well stated in the literature, but even reference products, lot to lot, could have some variability. And so Kaiser is also, we have a data network to try to capture that. And that's part of the conversation where we want to be prudent and dedicated to our efforts in pharmacovigilance. We recently, as an example of this, we were able to publish, or some colleagues of mine were able to publish our own experience specific to infliximab and switching. So it's somewhat like the efforts and the results seen with an example, the Norwich study in Europe. So that may give an idea of the US experience based on our own Kaiser data. So that's recently been reported, and we hope to continue to contribute literature and that kind of information to help guide the conversation around biosimilars. Now, in terms of follow-up and trying to maintain a good viewpoint on access and the approach to biosimilars, this is something, depending on the topic, it's something that we do try to monitor at least. Our P&Ts are scheduled every other month, so that's somewhat of a default calendar schedule for trying to bring these conversations into light, should there be an opportunity, but at least quarterly too. I think it depends. If you're looking at drug prices as example, as you stated, Jeff, typically those happen twice a year, January and July, so you could consider focusing on those two areas if that's the topic of interest. But we try to evaluate the opportunity, or at least look for updates, whether it's a clinical update, a cost update, at least quarterly, just so that we're aware of potential dialogue that may be occurring, so that we can address that as needed. And to Kathy's point again earlier, to make a shift, or potentially big shift, that does take time. So being able to monitor something regularly doesn't mean that we're going to want to transition quickly, but at least you can plan for it in a reasonable time frame.
All right. So I just want to have a mindful of time, and I want to try and take a couple questions. So I have one question for the group, and we'll go around, and then we'll take a couple audience questions, and they've been coming in, so that's fantastic. So as we mentioned, that in the very near future, we can have an area where there may be 9 biosimilars for a specific reference product, adalimumab, and that's anywhere coming near 2023. So give me your thoughts on how you are planning what you're doing today for that far out. So, products that may be coming in the next 1 to 2 years, obviously those are going to be a little bit different than you may be thinking further down the line. But what's your mindset, your organization's mindset for looking towards the future in biosimilars, arranging your contracting, logistics, anything along those? What have you been started? Ali, let's start with you.
So in the year 2023, I will give you the next lottery number so everyone can actually take that. I'm totally joking. And I think it's, to say 2023 is so far ahead right now, I think it's a little bit too early. I think if we get at least notification within 6 months to a year, I think that's good enough in regards to what we're looking at. I think the biggest premise that if we're looking forward to the evolution, again, as you talked about adalimumab, but what about, let's say Prolia, right? Very common. We'll say it's going to happen in about 5 years. We'll see a biosimilar. I don't know the exact date on that, but we have those numbers. If that's the case, we may look at that. It's going to be approved maybe June of next year. Great, it's on the horizon. We may actually look for implementation within 6 months behind that period of time, and then look at our IT and other structures, as well as monographs and other pieces too. And that's going to happen across the country. I think the key piece here looking that far forward will not be the buy and bill discussion, which Kathy had, brought on very early in this piece. It will be, what will our models for reimbursement look like in oncology? And I think that's going to be the key question for me. Right now, as I talked about before, with these new alternative payment models under CMMI coming out, you've heard Kathy really discuss the shared savings model discussion. Again, not a huge piece, but a piece of that puzzle, which is so important to reduce costs. And Tim also addressing his system as well, looking at this overall framework for implementation, very important. When we're taking a look at these pieces, one of the considerations that we're going to have to address is, what can we afford? And I think that implementation piece for what policies will develop for payers, and also what we have to adhere with, will either allow us to have a quick uptake of a biosimilar, or still actually maintain this discussion of buy and bill based on products, and also looking at policies developed by payers for either rebate discussions for preferred formulary medication as well. So I think that's what I'm looking for, more than the actual biosimilar discussion about what's coming up in the near future.
Okay. Kathy?
Well, I mean, very very simplistically, though, biosimilars are still going to be, at least, I can't imagine what 2023 is going to look like. I mean, come on, guys. Did we really think back in October of 19 we'd be talking about COVID? So we really can't crystal ball what 2023 is going to look like. But as far as biosimilars within my practice, until there's some major shifts, it's going to be dictated by the payer. So I can't really crystal ball it for you. I hope by then we will have shared savings models. We'll have a larger, robust collection of real world data to where these changes can start occurring. But until we work with parity, until there are other shifts within those forces, what I stock and what I administer will be currently payer driven.
Okay. Tim, your thoughts?
Yeah, no, I'd have to echo my fellow panelists. I think there's definitely a lot of uncertainty about biosimilars, especially that far out. But I do think it's this has been well stated as well about biosimilars, but really it comes down to access and affordability in very complex healthcare system that we have here in the United States. And so I think that policies that, whether it's about rebates and the incentives and disincentives that can come from that, coverage, shared savings model, as Kathy and Ali had mentioned, ultimately, I think what we want to see are policies, and these may all be steps in the right direction, or at least the policies that have been proposed speaking to those examples. But I think ultimately, if there are incentives in place to help bring more focus to the biosimilars, and it doesn't have to be just one, biosimilars in general, I hope, just to make it not so complex as it currently is. I think that's better for everyone. Because I think that's, it's just, I focus on oncology, and it's just crazy in terms of the trends that you're seeing, the value. Don't even get me started on surrogate endpoints. But I think that's very important but to get back to your question about the potential in 2023 and adalimumab, with the oncology experience, to echo some of the concerns too, approaching therapeutic oncology, we started that dialogue about 2 years in advance, trying to prepare for the potential pushback from clinicians, from patients. We heard things like, what if someone gets a second opinion and they feel strongly about a specific biosimilar, or they feel strongly against biosimilars? That was a consideration that we had to incorporate too. What are KOLs saying around the country? So I think, there's that uncertainty aspect, but we want to do our due diligence and be prepared should that time come. Obviously, recently, we were hoping for earlier access to biosimilars with the etanercept. So you just never know. But I think starting that dialogue early is important.
Okay. Well, and you said early, and you even started you said conversations a year or two in advance. I mean, it's well, I don't know, this is kind of like the 87th of March at this point, but so I know we can't go further past this year, but starting to think about that expansive market, are there things that you're thinking about now, again, for such a wide, wide slew of biosimilars for, any specific reference product?
Yeah, I think, we hope that with biosimilars, there's just a growing appreciation for how they're approached, whether it's a regulatory standpoint or the evidence surrounding them. So I think that approaching a new market like adalimumab would be a service to kind of describe the overall similarities that they may share, whether it's what their analytical data is or how they're approaching their studies, and also trying to show those caveats and try to incorporate beyond just the regulatory package. Are there opportunities or ongoing studies or pipeline studies that are looking at the potential for switching, as an example, or other institution experiences that may help contribute to a specific product story, or at least just build confidence in an overall arena? So I think that's the kind of conversation that would help with, in my opinion, the biosimilars in general. But if it helps dictate the message in one direction, if that's the kind of structure and approach an institution or a group wants to take, that's why I think early discussion is helpful, to kind of get those feelers out there, try to deal with misconceptions early as well, but overall just build confidence in biosimilars, and ideally, if there are opportunities to talk about policy to improve on access and affordability, I think roll that into the conversation to bring better public awareness.
All right. Thank you, Tim.
I would say, just to add that quickly, it would be interesting to see, looking at policies and payers, but also looking at potential research. One of the things that we look at is, maybe even Y-siding the biosimilar trastuzumab with the pertuzumab. So, there's data there looking at maybe same-day Neulasta with payers. Is that going to be an option versus the current product too? Or if you're looking at sub-Q versus IV, is that sub-Q, will that actually cost you more in the end versus an IV biosimilar, even though it creates less chair time? So I think there's evaluations and models there that can be really appreciated by working with institutions and also working with payers and pharma to address what is that cost of care model, so everyone has the same aggregate number when looking at that therapy or therapeutic policy treatment.
Absolutely. All right, so let's take a couple questions, and then it's been a fantastic conversation, and I think we can certainly go in so many different areas, only scratching the surface. First question, and I think given the opportunity for parity, we have multiple products or whatnot, are there other things that, all being equal, whether it's price, access to payers, and is there an opportunity for the biopharmaceutical manufacturer, that type of support program? Kathy, I know you had mentioned, you wanted to see more from manufacturers. If someone was providing more support, demonstrated leadership, is that enough for a tipping point in certain situations?
I think it's definitely worth considering. Ali mentioned it earlier. We need, what do their patient assistance programs look like? A lot of people need patient assistance. Is it a $5 copay? Is it a $20 copay? What does their hub look like? Our financial counselors live and breathe with this stuff. It needs to be easy, wet signature, versus mail-in. I mean, all of those things matter, and that matters on any drug that we use. If the patient assistance hub is problematic, we're less likely to use that drug. But so yes, that does matter for me. It also matters, but the contract matters. And I would like to see more in that education piece. I would like to see non-branded education for the nurses, the clinicians, our front office staff. Ali mentioned that earlier. You really have to have that whole team buy-in to make these things successful. And I would like to see more of that from our pharma partners.
Okay. Ali?
I there's a lot to say, but very little time to say it. So I'll try to be as brief as possible. But I think that I'm going to actually agree with Kathy on this one. I think there's two things I'd like to see. I would love to see non-branded education that can be 5-minute in-services, right? Quick, easy, succinct, provides information and prevents medication errors, and also ensures revenue integrity in the system. So that's one thing. But I also like to see the expanded discussions, really what Tim's working on in the future, those expanded discussions on potential reduced costs, pharmacovigilance, maybe other areas, like, for example, looking at cost models, implications of being between a biosimilar or brand name product, and what that means in a sub-Q IV format. And in fact, biggest question right now in the market is same-day growth factor. What does that mean? Can you use same-day Neulasta or same-day biosimilar in these cases for that discussion across the board? So I think there's a lot of opportunity there that does pop up that we'd like to see more education on, but also more research on, so we can feel comfortable with these pieces.
Okay. Tim, if there was, again, other options, and it sounds like, being more on the research, if there was other support, is that something that within Kaiser that might influence your choice in selection of a manufacturer, if they're providing better support? And
Yeah, no, I think I have to echo my fellow panelists here as well, where, there really is a practicalness to some of these discussions too, because I think you may often hear the question, if all these biosimilars are approved through the same pathway, they may have their unique kind of approach into the data, but ultimately they're still approved biosimilars. So how would you distinguish? So if it is something like having additional materials for a specific biosimilar, or if, like I mentioned earlier, if it's just easier to have a discussion where the data happen to look at a specific population, or if like with Truxima's example, that there was some real world data available at the time about switching, and there may not have been with some of the other rituximab biosimilars, there's just potentially could have that practical aspect to it where that conversation is already at a higher kind of baseline to have that with key stakeholders. So I think any available information, patient education materials is using the example, or circling back to the example, is very important and can play into that decision making.
All right, very good. Okay, I think we are going to be at time. Everyone on our panel, thank you so much for a wonderful and robust conversation. Again, we can certainly spend lots of time to talk about this. And every stakeholder is incredibly important, and especially focusing on what's best for our patients. So thank you so much for a great conversation. Everyone who joined us, thank you for spending your evening with us. If you would like to see this, it should be available on ajmc.com to share with colleagues. For AJMC and for our panel, my name is Jeff Prescott. Thank you for joining us. Have a great day.
Bye, everyone.